Okay, let's dive right into this explainer from the Anesthesia Learners Academy. Today, we're breaking down a topic that is absolutely massive: anesthesia and bleeding disorders. We've designed this session specifically for you PG students to give you the absolute high-yield pearls on inherited coagulation disorders. The exact stuff you need to completely crush your fellowship exams. Our sources actually set the stage perfectly here, calling these disorders a, quote, terrifying risk of catastrophic perioperative bleeding. And they're right. Getting the management right here isn't just about passing a test. It is literally a matter of life and death for patient safety. So here is our roadmap for today. We'll quickly cover the coagulation cascade basics, then get into the high-yield inherited blood disorders, talk about pre-op assessment and optimization, tackle intraoperative care and regional anesthesia, and wrap it all up with post-op care and emergencies. This whole pathophysiology to perioperative practice pipeline, it's exactly the mental framework you want for structuring your written and Viva answers. All right, Section 1, the coagulation cascade basics. Let's look at modern testing beyond just your standard PT and APTT. Well, you already know standard tests are notoriously slow, right? But TEG and ROTEM? These are highly testable, modern point-of-care tools. They're viscoelastic tests that give you a really dynamic, global picture of the entire clotting process. You're no longer just staring at isolated numbers. You're actually watching clot initiation, clot strength, and clot lysis happen in real time. It's a total game changer. For your exams, you've got to memorize these visual mnemonics. If you see a tracing shaped like a champagne flute, that points straight to hemophilia, meaning you've got a problem with fibrinogen or platelets, and you're going to want to treat that with cryoprecipitate or platelets. Now, on the flip side, a teardrop tracing means hyperfibrinolysis. The clot forms, but then it breaks down way too fast. Your treatment there, an antifibrinolytic like tranexamic acid. Moving into Section 2, high-yield inherited blood disorders. Let's get into the pathophysiology you absolutely must know. Okay, let's differentiate the specific pathologies they're going to test you on. Hemophilia A is your factor VIII deficiency, and Hemophilia B is factor IX. Remember for your MCQs, both of these are X-linked recessive, which is why we see them almost exclusively in males. But, and here's the real kicker, a full 1/3 of these cases are spontaneous mutations with absolutely zero family history. So please, don't let a negative family history trip you up on a clinical vignette. Now, the pathophysiology of sickle cell is a classic exam question. Sickle cell disease is caused by a homozygous single amino acid substitution. It's valine replacing glutamic acid on the beta chain. When hypoxia hits, this mutant hemoglobin polymerizes and sickles the cell. Sickle cell trait, however, is heterozygous. These patients generally live a normal lifespan and, crucially for us, they don't carry an increased risk for intraoperative morbidity. On the other side of the coin from bleeding, we have the thrombophilias, the clotting disorders. Factor V Leiden is the most common one you'll see, but pay really close attention to protein C&S deficiencies. Why? Because they carry a massive lifetime risk of venous thromboembolism. We're talking over 8 times higher than the general population. For these folks, you absolutely have to ensure aggressive VTE prophylaxis throughout their entire care journey. Section 3, Preoperative Assessment and Optimization. This is all about setting up for success. So the most crucial thing here is how rigorously we prepare these patients before they ever roll into the operating theater. Honestly, preoperative history is your single best tool. Always ask really specific questions to gauge that mucosal bleeding risk. Ask them, do you bleed when you brush your teeth? Or how long did you bleed after your last tooth extraction? Oh, and a multidisciplinary hematology consult? That's mandatory. You simply cannot fly solo on these cases. These optimization targets are pure gold for your written exams, so lock these in. For major surgery and a hemophilia patient, you want to hit exactly a 100% factor level, and you maintain that for 2 to 6 weeks post-op. For von Willebrand type 1, DDAVP, or desmopressin, needs to be given 60 to 90 minutes prior to surgery. And for sickle cell disease, you're targeting a pre-op hemoglobin greater than 8, with hemoglobin A making up more than 40%. Let's jump to Section 4, Intraoperative Care and Regional Anesthesia, Navigating the Danger Zone. For your sickle cell patients, your entire anesthetic strategy intraoperatively has to be hyper-focused on avoiding the triggers of a vaso-occlusive crisis. You must avoid hypoxia, hypothermia, and acidosis at all costs. You also want to avoid vascular stasis, which basically means tourniquets are a really bad idea. And here's a fantastic clinical pro tip. Always try to schedule these patients as the first case of the day. It minimizes their fasting time and keeps dehydration at bay.
All right, here is that controversial Viva question examiners absolutely love to throw at you. Is regional anesthesia an absolute contraindication in patients with coagulopathies?
The bottom line is that neuroaxial blockade is generally contraindicated. The risk of an epidural hematoma in that closed spinal space causing permanent paralysis is just a profound, terrifying nightmare scenario. Now, is there an exception? Only, and I mean only, if you have hard, documented proof that their factor levels are strictly normalized above 50%. And honestly, even then, it's highly debated and requires extreme caution.
Finally, Section 5, Postoperative Care and Emergencies, Managing the Aftermath.
Post-op, you have got to be on high alert for acute chest syndrome in your sickle cell patients. It's actually a leading cause of adult mortality. The protocol is straightforward but absolutely critical. Prevent it using incentive spirometry and really strict pain control. Diagnose it early and treat it aggressively with bronchodilators, antibiotics, and if they're crashing, an emergency exchange transfusion. For general post-op care in patients with bleeding disorders, stay far away from NSAIDs for pain management because they mess with platelet function. Instead, lean heavily on multimodal analgesia. Think acetaminophen and regional blocks if they're safe. You also need to institute mechanical DVT prophylaxis, like pneumatic compression devices, right away. And of course, monitor those factor levels like a hawk, sometimes for up to 6 weeks if it was a major orthopedic procedure. Before we wrap up, I want to leave you with this really provocative thought from our sources regarding the future of hematology. As gene therapy and cellular engineering continue to evolve, are we actually moving toward a future where we don't even need factor replacement? It's a super fascinating question, and it's one that could completely flip how we manage these patients in the coming years.
Definitely something to ponder. But hey, please remember this quick disclaimer. This explainer is designed strictly for educational and PG exam preparation purposes. It is absolutely not intended for solo clinical practice or direct patient care. Always, always bring in your multidisciplinary team and consult your hematology specialists when you're treating real patients.
Well, that's it for today. If this high-yield explainer helped clarify things for your studying, please go ahead and hit that like button, subscribe, and share it with your colleagues on the Anesthesia Learners Academy platform. We are on a mission to help as many PG students as possible crush their fellowship exams. Thanks so much for tuning in and keep studying hard.